In this module of pediatric rheumatology disorders, I will start with a discussion of an important topic called as juvenile dermatomyositis. And here is a one-liner question. This is the most common inflammatory myositis in the childhood. As you can infer from the name, myositis is inflammation associated condition. So this is the most common inflammatory myositis in childhood. Okay. Right, that's the first important one-liner you should know. Second important point is, as you can infer from the name, that dermatomyositis, in addition to muscle manifestation, you will have skin manifestations also. In fact, the presence of the skin manifestation is what actually leads to diagnosis of dermatomyositis in children. Now let's have a look at the skin manifestations. The first manifestation is what you see in the picture A. Can you notice that surrounding the eye, there is a reddish, or it is more like a purplish discoloration, or what we also call it as a blue-violet erythematous rash around the eyelids. And this name is a very characteristic name called as a heliotrope rash. That's a main feature of juvenile dermatomyositis. And associated with that, you will also have edema surrounding the eyes, which is what we call it as periorbital edema. So that is the number one feature of juvenile dermatomyositis in the skin features. The next finding is what you can see in the picture B and C, where you can notice that there is some scaly red lesions in the skin of that area. Can you notice the location of that area? One is over the skin of this joint. What is that? Metacarpophalangeal joint area. And second is over the skin of the interphalangeal joint area, where you see some red colored scaly lesions. And this is the second characteristic skin finding called as the Gottron's papules. Gottron's papules. Okay. What is the description? It is nothing but erythematous, scaly lesions on the skin over the joint regions, especially the metacarpophalangeal joint as well as the interphalangeal joint area. This surface is what we call as a dorsal surface. Okay, so this is the description of Gottron papule. These two are very important findings which are associated with juvenile dermatomyositis. Okay, so as I was telling you in the diagnostic criteria, the skin findings are very, very essential for diagnosis. That is number one. Number two, I am going to tell you the other set of manifestation, that is in the muscle features. Out of that, any three of the following should be present. The first one which is included is symmetrical and proximal muscle weakness. What is the meaning of this proximal muscle weakness? It is nothing but in the limbs, the proximal group of muscle. For example, upper limb, the shoulder muscle, lower limb, the thigh muscles like that, they will be affected symmetrically. That is what is called symmetrical and proximal muscle weakness. And what is the other finding which you are going to get? Any patient with a proximal muscle weakness, you will have a typical finding called as a Gover's sign positivity. I have discussed this already in the module of neuromuscular disorders. What is the meaning of Gover's sign? If the child is sitting and you ask the child to get up from the sitting position, the child will not just like that get up, but will use the upper limbs, especially that hands, as a support over the thigh region, and then will slowly get up. This is because the thigh muscles or the proximal muscles are weak. So the child uses the hands as a support to get up from the sitting position. That is what we call it as a Gover's sign. I have explained this with a picture in the module of neuromuscular disorders. Okay, next important finding could be elevation of the muscle enzymes. You can see the muscle fibers are inflamed and undergo destruction, so the muscle enzymes would get released into the circulation. The important group of enzymes which can be elevated are the creatinine kinase and the aldolase. They will be elevated in case of this dermatomyositis. The third important is you can do an investigation called EMG. That EMG will show short motor unit potentials and fibrillations. Okay, right. And last is regarding the muscle biopsy. Muscle biopsy will show evidence of necrosis of the muscle fibers or evidence of inflammation in the muscle fibers. Okay, so as you can see, all these four features are related to the muscle involvement in dermatomyositis, and out of these four features, any three should be present along with the rash to make the diagnosis of juvenile dermatomyositis. Now have a look at this picture. What you can see is a red colored lesion over the, see, this is that chest area, the neck area above, and this is the anterior part of the chest. Okay, the upper and the anterior part of the chest. You can see some red colored lesions, okay, in the anterior part of the chest. It is a sun exposed area, and this finding is what we call as Scholl sign in case of juvenile dermatomyositis. Please remember, this sign is not included in the diagnostic criteria, but one of the important associated features noted in juvenile dermatomyositis. The next finding is noted in some children in the form of thick erythematous scaly plaques in the skin over the palms and the soles, or skin over the fingers and in the toe region, and that is what we call it as the mechanic's hand. Okay, so mechanic's hand is nothing but the thick scaly lesions noted in the hands of a child with juvenile dermatomyositis. Now I have told you about the salient features of juvenile dermatomyositis. Some additional things which can be asked as one-liners in your exam includes the serology findings. Okay. Now most of the rheumatological disorders we keep looking for some antibodies. Okay, and that is what exactly I am going to write under serology. One group of antibody is what we call it as MAA. What is that? Myositis associated antibodies. Which are non-specific antibodies. Non-specific antibodies. Right? Here, the type of antibodies would be antibodies against SSA, SSB, and even anti-double-stranded DNA antibodies. You all know that these are not specific for this condition because you have studied them in other rheumatological disorders like in SLE as well. That is why they are called as myositis associated antibodies and not specific antibodies. Okay, right? The next group of antibody is what we called as MSA. Here S stands for specific antibodies. The typical examples of this myositis specific antibodies include antibodies against JO1 antigen. Second is antibodies against M12 antigen or M12 antigen. Okay, these are the important myositis specific antibodies which can be noted in children with juvenile dermatomyositis. Okay, finally we come to the treatment aspect of juvenile dermatomyositis. Remember, it's a rheumatological condition which is usually treated by decreasing the inflammation. That is why the name you can infer myositis. Itis means inflammation. So you have to use anti-inflammatory agent, and the commonly used anti-inflammatory agents for this condition are corticosteroids. Okay, right? Initially we use intravenous methylprednisolone, and then we use oral prednisolone in tapering doses. Okay, and the long-term treatment would be in the form of something called as methotrexate. Now this methotrexate is for a long-term treatment, or what we call it as a maintenance treatment. And please remember, to bring the disease under control, the usual duration of this maintenance treatment is for around 2 years. On an average, it is 2 years. So those are the important points regarding the first rheumatological disorder of juvenile dermatomyositis. The next condition is called as juvenile idiopathic arthritis, which is a condition characterized by the development of arthritis. And we all know the definition of arthritis. What is that? Arthritis refers to swelling in the joint area, or what I am writing as intra-articular swelling. And along with the swelling, you should have any two of the following, which includes limitation in the movement of the joint. Okay, limitation in the movement of the joint. Second is tenderness or pain while moving the joint. And third one is increased warmth over the joint. Out of this, any two should be present, and along with that intra-articular swelling, you call it as arthritis. And please note an important one-liner question here, that juvenile arthritis is the most common rheumatological disorder in children. And you should also know about the definition of juvenile idiopathic arthritis. It refers to development of arthritis in a child less than 16 years of age. Or in other words, the onset of disease is before 16 years, and duration should be for at least 6 weeks or more than that. So more than or equal to 6 weeks of duration. So you can see that this disease is not a disease of an acute presentation. It's like a long duration disease, and this is the reason why it is associated with so much of problems in childhood. For example, due to long duration of arthritis, the child can have significant morbidity along with school absenteeism as well as some emotional disturbances as well. That is why this disease is considered as one of the most common conditions associated with childhood morbidity as well. Okay, now let us start discussing about salient features of this particular condition. There are different subtypes of juvenile idiopathic arthritis. One is called as the oligoarticular JIA. What is the meaning of oligo? Oligo means less. Whenever less than or equal to 4 joints are affected, then it is called oligoarticular JIA. More than 4 joint affected is called as polyarticular JIA. And polyarticular JIA is subdivided further into rheumatoid factor positive and rheumatoid factor negative polyarticular JIA. Third important subtype is the systemic onset JIA, or simply remembered as SJIA. Fourth important is psoriatic JIA, and fifth one is enthesitis related arthritis. Okay. Now out of this different subtype, the most common subtype overall is oligoarticular JIA. This is the overall most common subtype of JIA. The next thing to be known is, generally juvenile idiopathic arthritis is more common in females compared to males. As with any other rheumatological disorder, this is also more common in female. However, exception to that are enthesitis related arthritis is more common in males compared to females. And second important thing is, in systemic onset JIA, males and females are equally affected. In all the other varieties, females are more commonly affected compared to males. Okay, now let us start discussing about the features of individual subtypes of JIA. First one is oligoarticular JIA. In this particular condition, the age group affected is usually in the range of 3 to 5 years. So you will see less children who are affected by this disease. And don't forget, what is the meaning of oligoarticular? Less than or equal to 4 joint affected is called oligoarticular. It is usually defined like this: 1 to 4 joint, okay, affected in the first 6 months of disease. It is called as oligoarticular JA. That is the complete definition of oligoarticular JA. Now this variety of JA is subdivided into two more types. One is called as a persistent oligoarticular JIA, number one. Next one is called extended oligoarticular JA. What is the meaning of the first one, that is persistent? Persistent means always there is 4 joint involvement only. That means what? Even after 6 months or during the lifetime of the patient, if less than or equal to 4 joint involved, then it is called persistent oligoarticular JA. So less than or equal to 4 joints involved at any time of the disease, okay, then it is called as persistent oligoarticular JA. Extended means after 6 months of the disease, more than 4 joints are affected, like 5 joints, 6 joints are affected, then it is called as extended oligoarticular JA. These are two subtypes of JA which one should be aware of. Okay. Now the commonly affected joints include most commonly the knee, followed by that ankle and the wrist joint. Okay, and equally important for us to know for the exam purpose is that which involvement is very, very unusual or rare. Okay, involvement of the hip joint is very unusual or rare. That is number 1 point. Second thing to be remembered is the small joints of the hands and feet, like interphalangeal joint, are not usually affected in this particular condition. So these two are the type of joints which are usually not affected in case of JIA. Okay, and in this particular condition of JIA, there are some extra articular findings also noted. Okay, and in this group of patient, there are some extra articular findings, the most common of which you should know about is chronic uveitis. And this chronic uveitis is something which is dangerous because it can result in potential blindness. Okay, that is why this condition should be looked for and treated. Especially if a patient is having ANA positivity, they are highly likely to develop chronic uveitis. This association is always very important and should be noted. Okay, now an interesting finding which is noted in patients with oligoarticular JA is that they have some type of HLA positivity which predisposes them to develop this disease. And what is that? It is HLA DR5 and HLA DR8. This is also a potential MCQ for your exams. So that is about the discussion of oligoarticular JIA. Next we move on to the discussion of polyarticular JIA. What is the meaning of polyarticular? More than or equal to 5 joints affected is what we call it as polyarticular JIA. And as I said before, we can divide this into two subgroups. One is rheumatoid factor negative, other one is rheumatoid factor positive. We all know that rheumatoid factor is IgM type autoantibody. If it is present, is called RF positive, negative is called RF negative. Okay. Now, in this condition also, there is a HLA positivity which has been noted. And for rheumatoid factor negative, it is HLA DRB1. And for rheumatoid factor positive, it is HLA DR4 and DR1. Okay. Now, let us look at the clinical presentation of these children. Now, first I'll start with the age. Okay, any age in childhood is affected in rheumatoid factor negative polyarticular JA, whereas in case of rheumatoid factor positive variety, it is usually seen in late childhood and in the early adolescence. The typical age group is often remembered as 9 to 11 years. Okay, right. Clinical picture, of course, is the description of arthritis only. Remember, arthritis of the lower joints are commonly affected. Remember like this, in rheumatoid factor negative variety, you have involvement of knee, hip and the wrist joint. Usually remember, there is a lesser tendency to involve the small joints of the hands and feet. Whereas for rheumatoid factor positivity, okay, you again have that large joints which are affected, but in addition to the large joints, you can also have involvement of small joints of the hands and feet. Very important, small joints of the hands and feet are affected. Additionally, cervical spine cervical spine, and TMJ, that is temporomandibular joints, may be affected. Okay, you can also remember that because of additional joint involvement in rheumatoid factor positive type of polyarticular JA, it is somewhat resembling the adult variety of rheumatoid arthritis as well. Okay, that is something which you should know about. Okay, next important is a symmetry. In case of polyarticular JA, it is a asymmetrical involvement, whereas rheumatoid factor positive variety is always symmetrical involvement. It is also additive, that is one after another joints will be added in a symmetrical fashion. That's important. Now last is regarding the association. Okay, and now rheumatoid factor negative polyarticular JA, if the patients are having ANA positivity, then they are at increased risk of developing chronic uveitis. Okay, whereas for rheumatoid factor positivity, there is no such association with uveitis, but these patients can develop something called rheumatoid nodules. Similar to what you see in adults with rheumatoid arthritis. What is that rheumatoid nodule? It is nothing but a non-painful nodule noted around the extensor surface of the joints, like in the elbow area or in the occiput area or over the region of Achilles tendon. That is what we call it as rheumatoid nodules. Usually remember, they are not a very common finding, but if present, they point towards rheumatoid factor positive polyarticular JIA. These are the main differences between RF negative and RF positive polyarticular JA. We now move on to the next category, which is called as systemic onset JA or systemic JIA. This is a very, very important and a serious disorder because this condition can present with additional findings. What are they? One is fever. Okay, and along with the fever, at least one of the following should be present. It could be in the form of a rash. It could be in the form of hepatosplenomegaly. Third one is lymphadenopathy. And the last one is serositis, like pleuritis or pericarditis. So fever along with any one of the four features I mentioned should be present. Then only you'll call it as systemic onset JA. Now there are some characteristic points about fever and rash in systemic JA that one should be aware of. You can see in this picture the depiction of fever spikes in a patient with systemic onset JA. Can you see that in every day? Okay, it is marked as M and E, which is morning and evening. You can see that this is the temperature range which is given like this. Okay, and this line is what we call it as a baseline, below which you call it as normal temperature and above which you call it as fever. What are you noticing from this picture? Very characteristically, every day, especially in the evening time, the child is having fever spikes. Can you notice that? So it is not a continuous fever but a intermittent fever spikes. Okay, intermittent fever spikes. They can have 1 to 2 fever spikes per day in the evening. And once that spike is over, you can see the temperature again coming back below the baseline. That means what? Temperature returns to normal after the fever is subsided. Okay, and this pattern of intermittent fever is what we call it as characteristically quotidian fever. Quotidian fever. Very characteristic in case of systemic onset JA. That is the first description with regards to fever. Second thing is, at the time of fever or during the fever spikes, these children also have this characteristic rash in the trunk. Okay, it is a non-pruritic rash and the appearance is maculopapular rash. Please remember, as I told you before, this is a rash which is associated with fever. So during fever spikes, they will be present, and once that fever subsides, they also will subside. So this is again a transient rash and not a permanent rash. It's a transient rash, maculopapular rash, and the characteristic color is what we call it as salmon pink color of the rash. Okay, right. Remember, these two are very, very important and common findings in systemic onset JIA. The next important is psoriatic arthritis. Please remember, it's a condition, as the name implies, is associated with psoriasis. Now, here is a point to be remembered. The arthritis with psoriasis can precede the development of psoriasis or can occur together with psoriasis or after the development of psoriasis. Okay, any form of presentation is possible. How do you diagnose this condition? You will diagnose when a patient having arthritis also has features of psoriasis. If psoriasis is not evident, they should have any two of the following, which includes, what do you see in the picture? Can you see in that nail, there are a lot of that pits like this present in that nail. This is what we call it by the same name, nail pitting. Okay. They can also have swelling of that entire finger, or what we call it as the dactylitis. Or they can have a first degree relative with psoriasis. And out of these three, if any two are present along with arthritis, you can also call it as psoriatic arthritis. The last variety is called as a enthesitis related arthritis. Now, in this particular condition, as I have mentioned before, males are more commonly affected than the females. Number one, usually older children are affected after the age of 8 years. So the onset is relatively older children in enthesitis related arthritis, and the usual joint which is affected is the lower limb joint, like the hip or the knee or the ankle region. Okay, and it is usually a asymmetrical involvement of the lower limb joints. Okay. And if you go back to the name, what is the meaning of enthesitis? It is, itis means inflammation. Enthesis refers to the area where the tendons are inserting into the bone. So in other words, this is nothing but inflammation of tendons at the site of attachment to the bone, at the site of attachment to the bone. Okay, that is what we call it as enthesitis. Okay, right. Now, one more important point is about the association with HLA-B27. HLA-B27. And these patients are also prone for developing sacroiliitis. This is a unique finding because you don't see this joint involved in any other form of juvenile idiopathic arthritis. So this sacroiliitis association is also a typical feature of enthesitis related arthritis, even though they're not usually seen in the childhood. Maybe in the late adolescence or in the adults only this manifestation develop. But please remember, in the presence of HLA-B27 positivity, there is a high chance of developing sacroiliitis. Okay, so I have told you about the salient clinical features of different types or different subtypes of juvenile idiopathic arthritis. Please remember, juvenile idiopathic arthritis is a clinical diagnosis, and the pattern of joint involvement actually gives clue to what subtype of juvenile idiopathic arthritis you are looking in a patient. Okay, I am going to tell you about the investigation part now, but please remember, the investigations are usually of little value in JAA because JAA is usually a clinical diagnosis. Okay, right. If you do the blood count, you can see low hemoglobin, which is anemia, and the reason for the anemia is the ongoing inflammation, or that is what we call it as anemia of chronic disease, which is noted in juvenile idiopathic arthritis. If you look at the WBC count, WBC counts can be increased and the platelet counts can also be increased as a part of ongoing inflammation. And especially very high counts like more than 30,000 WBC count is noted with systemic JA because that condition is associated with very high level of inflammatory activity in the body. Okay. Next thing you can look for is the X-rays. Remember, X-rays in the early stage of arthritis can be absolutely normal. So X-rays are a relatively poorly sensitive investigation in rheumatoid arthritis. So if there is a question, what is the most sensitive investigation to look for joint involvement? Okay, answer has to be MRI. Okay, so remember, X-ray is a less sensitive investigation when compared to MRI to look for the joint involvement in arthritis. Okay, suppose X-ray becomes abnormal, what are the findings you can expect? You can expect increased soft tissue swelling around the joint due to inflammation, increased soft tissue swelling around the joint, and second is surrounding the joints there is some degree of osteopenia as well. So peri-articular osteopenia. Okay, right. So these are two important X-ray findings which you can note in any case of arthritis. Third important is to look for the serology, that is to look for the antibodies. You can get ANA positivity and rheumatoid factor positivity as well in certain subtypes of juvenile idiopathic arthritis, but please remember they are no way going to help in the diagnosis. They have more of prognostic importance in the sense that very high levels of antibodies are correlated with the development of complications in juvenile idiopathic arthritis. So these are the important investigation that one may do in a case of JIA. But again, repeating the fact that JIA is purely a clinical diagnosis. Okay, so once we have diagnosed this particular condition, what are the treatment options? The main treatment should be to relieve the patient of the morbidity caused by arthritis, and that is the pain control. Generally remember, pain control is usually achieved by non-steroidal anti-inflammatory drugs. And the common drugs which we use for this purpose include naproxen and ibuprofen. Okay. Usually they are the agent of choice to control pain in arthritis. Suppose the pain is not controlled with NSAID alone, then you can give intra-articular injection of steroids. And the usual steroid for this purpose is triamcinolone. Okay, so main thing is regarding the pain control. Okay, and over a long period of time, we use disease modifying agents. Disease modifying agents, and the commonly used disease modifying agent is methotrexate. The second agent which can be useful is hydroxychloroquine. These two agents have an immunomodulatory effect, that is why they are used as disease modifying agent in rheumatoid arthritis. And finally, you should also be aware of some newer modalities of treatment. They are also called as biological agents in the management of juvenile idiopathic arthritis. This is based on the fact that there are a lot of inflammatory mediators which are causing arthritis in this condition. So if you can use some drugs against those inflammatory mediators, then this condition can be controlled. One such is interleukin 1 receptor antagonist called as anakinra. Next is some of the drugs which are directed against tumor necrosis factor alpha, which include typical examples of infliximab, etanercept, and adalimumab. Okay. One more is interleukin 6 receptor antibodies, which are called as tocilizumab. And last one is an inhibitor of T cell activation, which is called as abatacept. So these are the important new group of agents proposed for the management of juvenile idiopathic arthritis. So remember, juvenile idiopathic arthritis is the most common rheumatological disease of childhood and is also the most common cause of morbidity associated due to rheumatological disorders. Remember, it can have multiple types of presentation, out of which oligoarticular JA is the most common type. And JIA is always a clinical diagnosis. Investigations are of little help in this particular condition. The mainstay of pain management is NSAID, and the usual drug for long-term management is methotrexate. So that is about the discussion of juvenile idiopathic arthritis in children. The next condition I am going to discuss about is Henoch-Schönlein purpura, which is abbreviated as HSP. This is one of the common vasculitis in children. Please remember that in pathology, when we study about vasculitis, we divide them according to the size of the arteries which are affected, namely small vessel, large vessel and medium vessel. Where does HSP fall under? It is small vessel vasculitis, right? So it's a small vessel vasculitis of childhood. Okay. And because in this particular condition, IgA deposits are noted in the blood vessel, it is also called as IgA vasculitis as well. And the other names of this condition which one should remember are purpura rheumatica. It is also called by one other name, which is leukocytoclastic vasculitis. This leukocytoclastic term refers to the presence of neutrophils or the debris of neutrophils found in and around the affected blood vessels. So these are the alternate names of Henoch-Schönlein purpura which one should be aware of. In this particular condition, the characteristic feature is what leads to the name as Henoch-Schönlein purpura, which is given in this picture. The typical age group which is affected in this condition is 4 to 8 years. Let us see about the important features of this particular condition. The most important feature is what you are going to see in this picture. You can notice that the lower limb of this child is shown and you can see those bleeding spots over the skin. What are they called? They are called as purpura. Generally, in which condition do you study purpura as a manifestation? It is usually associated with thrombocytopenia, but in this particular condition, the platelet counts are normal. It is only due to vasculitis that the child develops purpura. That is why it is also called as non-thrombocytopenic purpura. Okay, and please remember that if you touch that area, you can even feel that purpura also. So that is why it is also called as palpable purpura. And usually remember the site where purpura is noted in this condition. It is usually in the lower limbs and in the buttocks region. It usually does not affect the upper part of the body. So the main and the characteristic feature of HSP is the presence of palpable purpura. They can even put up images along with the clinical scenario to ask you about the diagnosis of Henoch-Schönlein purpura. So as I said, the most important feature is the purpura. The other findings would include presence of arthralgia or sometimes arthritis. These patients can also have abdominal pain following intake of food, or what we also call it as postprandial abdominal pain. And they can also have renal manifestations in the form of nephritis. Okay, and if you do biopsy from the affected area, for example skin biopsy, you will see the presence of IgA deposits in and around the blood vessel. So IgA deposition is the main feature which you notice on biopsy. That is why it gets the name itself as IgA vasculitis. Okay. Now, to make your diagnosis of Henoch-Schönlein purpura, the most important feature is the presence of purpura. And along with the purpura, any one of the four which I have written below should be present. What is that? The child should have either arthralgia, arthritis, or postprandial abdominal pain, or renal manifestation, or a biopsy showing IgA deposits. If any one of this is present along with purpura, then your diagnosis is Henoch-Schönlein purpura. So as I have said before, what happens to platelet count in HSP? It is absolutely normal, okay, because it's a non-thrombocytopenic purpura. Second thing, I told that renal involvement in the form of nephritis can be present. But please note this important fact that renal manifestations are usually not an acute feature or the presenting feature of the disease. They develop later in the course of illness. So that is why if there is a question asked that what would be the initial urine analysis finding in a patient with Henoch-Schönlein purpura, remember it is initially normal. Later only they may develop urinary problems like nephritis. So that is why follow-up of a child with HSP is needed for the next 6 months to detect any development of renal disease. That's a point to be noted. So again, repeating the fact that renal manifestation are not an acute problem in HSP, rather they are a chronic problem in HSP. Okay, if at all it develops. Okay, the next thing to be remembered is what is the outcome of a patient with HSP. Remember, they have an excellent outcome. Okay, there is no need to worry much about these patients because they usually recover without any problems. The next thing to be remembered is the prognosis or outcome of this patient is usually excellent. They usually recover without any problems. A very small number of children may develop some complications. And these complications can either be an acute complication or it could be a chronic complication. The acute complications are usually gastrointestinal, and the usual acute gastrointestinal problem is intussusception. Okay. And the chronic problem usually occurs in less than 2% of the children, and that is in the form of a renal damage, and which can progress on to chronic kidney disease as well. But remember, I have already mentioned that only a small group of children are going to develop these complications. In general, the prognosis is always very, very excellent in Henoch-Schönlein purpura. The last rheumatological disorder which I am going to discuss is a very, very important vasculitic disorder, again called as Kawasaki disease. Please remember, Kawasaki disease is a medium vessel vasculitis. And what is the update here? This is the most common vasculitis in childhood. Very important. Most common vasculitis of childhood in India is Kawasaki disease. Previously it was Henoch-Schönlein purpura. Now it is Kawasaki disease. The age group of the children affected by Kawasaki disease is usually less than 5 years. And it's a disease of unknown or idiopathic etiology. Just like most vasculitic disorders, this is also a disease of unknown etiology. Okay. Now, when we talk about the features of Kawasaki disease, they have divided the timeline of Kawasaki disease into 3 phases, namely the acute phase, subacute phase, and the convalescent phase, or what we call it as the recovery phase. Okay. Acute phase lasts for first 1 to 2 weeks. Subacute phase for 3 to 4 weeks. And recovery phase is around 6 to 8 weeks. Right. Now, it is very, very important to diagnose Kawasaki disease at the earliest, and that is why you should know about how to make a diagnosis of Kawasaki disease in the acute stage of illness itself. Okay. In acute stage of illness, the characteristic feature of Kawasaki disease is prolonged fever. Very, very important. This is the most important feature of Kawasaki disease, which is prolonged fever of more than 5 days duration. Okay. So most of these children initially will be treated as some other infectious disease with some antibiotics and so on, right? So it is a fever which is the most important feature that one should look for in Kawasaki disease, especially if there are no other focus of infection in a prolonged fever. Please think about Kawasaki disease in children. Okay. Next thing to be remembered is along with fever, there are other manifestations also which can be remembered by a very famous mnemonic called as CREAM. I'll take up the picture to tell you about the other manifestations in acute phase of Kawasaki disease. Look at the first image, that is for C, which is bilateral redness of the eyes. So it is bilateral conjunctivitis. Because it's a non-infective condition, you don't have any pus discharge coming out. So it's called bilateral non-purulent conjunctivitis. Okay, that would be for C. Right. Next one is the R. R refers to the non-specific maculopapular rash. Right. It can be present anywhere in the body, in the trunk or in the limbs, but it is not having any specific or a characteristic feature. So R for rash, which is maculopapular rash. Okay. Then E. E for the changes in the extremities. E for changes in the extremities. Okay. Now this changes in the extremity can be remembered as acute changes, changes in the acute phase, and changes in the subacute phase. The changes in the subacute phase is of interest to us because we need to diagnose the condition early, right? So what are the acute phase changes? These include edema of the limbs as well as redness of the limbs or erythema of the limbs. What about subacute phase? It is shown in this picture. What can you see? Surrounding the nail region, okay, you can see lot of skin peeling. So it's called periungual desquamation. Periungual desquamation, which is simply remembered as skin peeling. So C, R, E. What is the next one? A. A for, it's not shown in the pictures here, so I will write it separately. A here stands for adenopathy or lymphadenopathy. Okay. Usually one lymph node in the neck region is enlarged. So it's a single cervical lymphadenopathy. Okay. And what is the last one? M. M stands for the mucosal involvement. Typically, it is a redness of the mucosa in the oral region. Can you see in this picture? There is lot of redness in the mouth region as indicated by redness of the lips as well as redness of the tongue region. Okay, what is that lip redness called? Cheilitis, and the tongue redness is called as glossitis. And this tongue is so reddish, it gets a characteristic name as strawberry tongue. Okay, right? Strawberry tongue. Okay, so that's about the characteristic findings which are noted in case of Kawasaki disease acute phase, remembered as a mnemonic cream. Now, what are the features of the Kawasaki disease in the subacute phase? Okay, one, as I have already mentioned in that picture before itself, there would be periungual desquamation. Second, you will have thrombocytosis, increase in the platelet counts. And third is a very important complication which can occur in Kawasaki disease, and that is development of coronary artery aneurysms. Coronary artery aneurysms. It is the most feared complication in Kawasaki disease, and it has been said that if you can diagnose Kawasaki disease in the acute stage and start the treatment, we can even decrease the incidence of coronary artery aneurysms. So that is why it is very, very important for us to diagnose the Kawasaki disease in the acute stage of illness. See, convalescent stage is nothing but recovery. Okay. However, before reaching the recovery state, some children can develop coronary artery aneurysm, and the incidence of coronary artery aneurysm is somewhere between 20 to 30%. That's a high number, and considering that it's the most common vasculitis in India, you should always try to diagnose this condition very, very early or in the acute phase of illness. That is what is bringing us to the diagnostic criteria for Kawasaki disease. What is that? It is presence of fever for at least 5 days duration. Along with that, in that cream, CREAM, how many things are there? CREAM means 5 things are there. Out of that 5 other features at least 4 should be present. At least 4. So 4 out of 5 other features in addition to fever, you will make the diagnosis as Kawasaki disease. Okay, right. Please remember, as soon as you make the diagnosis of Kawasaki disease, you have to start treatment, the details of which I will be discussing shortly. Okay, now in some of the children, there can be presence of fever, but they don't have 4 out of 5 in that cream criteria. They have less than 4 criteria. For example, 3 criteria out of 5. Then what will you do? In these children, you will call it as incomplete Kawasaki disease. Incomplete Kawasaki disease. I am writing as KD. KD refers to the Kawasaki disease. In incomplete Kawasaki disease, you have to do echocardiography. And if the echocardiography shows any involvement of coronary arteries, then you have to start treatment like for Kawasaki disease only. So that is important. Okay. So less than 4 criteria is called incomplete Kawasaki disease, but along with coronary artery problems, you definitely have to treat that particular child also. Okay. So that is about the important features and outline in the management of Kawasaki disease. I would also want you to be aware of some other features other than that included in the fever and the cream mnemonic. Some features which can be noted in children with Kawasaki disease. What are they? Please concentrate on the last 2 pictures. Let's imagine that this is the arm of the child and this was the region of BCG. Okay, let's imagine. Can you see that in the region of that BCG area, there is lot of this swellings like that are occurring. Along with that, there is some redness also occurring in that area. Okay, and if you touch that area, it will be very hard, or what is called as induration will be present. This is what we call it as reactivation of BCG scar, which is another important feature, even though not included in the criteria. Now look at the last picture, which is the anal region which is shown. Surrounding that anal region, there is lot of skin peeling noted. So it is perianal desquamation. That is also a feature of Kawasaki disease, again not included in the criteria. So there are 2 other features which I have already mentioned. One is reactivation of BCG scar, other is perianal desquamation. The other findings are, if you do the ultrasound of the abdomen, you can see hydrops or distension of the gallbladder. You can also get this finding of sterile pyuria, presence of pus cells in the urine, but the culture can turn out to be negative or sterile. And the last set of features are relatively rare features but can be associated, which includes aseptic meningitis, arthritis, or sometimes hepatitis. Okay, so please do remember, these are not included in the diagnostic criteria, but some other important features which should be remembered while reading about Kawasaki disease. Now, what are the complications in Kawasaki disease? It is mainly related to the heart or the cardiac complication. This cardiac complication can occur in the acute stage or in the subacute stage. In the acute stage, the usual set of cardiac complication is something related to myocarditis. And this is actually the commonest group of cardiac complication occurring in Kawasaki disease. Around 50 to 70% of complications are in the acute stage. Remember, most of the time, myocarditis is usually resolving spontaneously without causing much of problems. Very rarely, it can lead on to a heart failure, but most of the time, the patient recovers without any residual problem. Okay, so myocarditis is something which is seen in the acute phase. Subacute phase is where you have this coronary aneurysms, and this is what is the severe set of problems which can occur in a patient with Kawasaki disease. Okay, remember, as I have said before, coronary aneurysms occur in 20 to 30% of patients with Kawasaki disease. So when you compare the incidence of complication, it is relatively lesser, but it is more severe when compared to myocarditis, because coronary aneurysms can be associated with increased risk of mortality. The reason being, it can be associated with rupture of the aneurysm, especially if the size is more than or equal to 8 millimeters. Okay, right? So that is why we are always very worried about coronary complication, especially coronary aneurysm, and that is why we need to diagnose the Kawasaki disease in the early stage of the disease itself to prevent this coronary aneurysms from occurring. Okay, so as I have said before, the diagnostic criteria is based on fever along with 4 out of 5 in the cream, or in case of incomplete Kawasaki disease, you have to do the echocardiography, and if the echo shows coronary aneurysm, then again treat as a case of Kawasaki disease. So now we need to know about what is the treatment of Kawasaki disease. The drug of choice for this particular condition is IVIG, which is intravenous immunoglobulin. You give this as intravenous infusion in the dose of 2 grams per kilogram as IV infusion you are going to give, and along with IVIG you can also give aspirin. It is usually given at the dose of 80 to 100 milligram per kilogram. This is actually what we call it as a high dose aspirin. And why is high dose aspirin advised? Because of its anti-inflammatory effect. Because of its anti-inflammatory effect. How long should you give this high dose aspirin? It has to be given till the patient is afebrile for at least 48 hours. Till the time you have to continue high dose of aspirin. And once he is afebrile for more than 48 hours, then you can bring down the dosage of aspirin to low dose aspirin. And typically low dose of aspirin is remembered as 3 to 5 milligram per kg per day. And this has to be continued till 6 to 8 weeks. Okay, that is continued till the convalescent or the recovery stage of the disease. And once the 6 to 8 weeks of treatment is done, you have to do the echocardiography. If the echocardiography is normal, there is no evidence of any coronary aneurysm, then you can stop aspirin at this point of time. If the echocardiography shows presence of aneurysms, then you have to continue aspirin till all the coronary abnormalities have been normalized. Okay, so this is the management in a child with Kawasaki disease. Remember, always IVIG is the drug of choice, but aspirin is an additional treatment because of the benefits of anti-inflammatory effect in a high dose as well as anti-platelet effect in the low doses. Now that completes our discussion of Kawasaki disease. And please remember that Kawasaki disease is now the most common vasculitis of childhood. It's a disease of unknown etiology, but the main problem is development of coronary artery aneurysm. And please remember again, the fact is it develops usually in the subacute stage of the disease. So it is always important for us to diagnose the Kawasaki disease in the acute stage itself. That is with the help of fever and the cream mnemonic. Okay. And remember, once the diagnosis is made, you should immediately start treatment with IVIG along with aspirin. In that way, the coronary artery complication can be greatly decreased, and this can bring down the overall mortality due to Kawasaki disease as well. So that is about the discussion of Kawasaki disease.